Okay, I'd like to thank Byron for inviting me to speak today and give you a little bit of history and recent progress on our efforts to facilitate standing and transfers and upright mobility after spinal cord injury. He didn't ask me to talk about trunk control, which is a passion right now and really important, as Harry said, but I'm happy to talk to anybody privately about that afterwards. Um, I am the executive director of the Advanced Platform Technology Center at the Lewis Stokes VA in Case Western, sort of the sister center of the FES Center. As Bob mentioned, we focus on restorative and assistive technologies, primarily in prosthetics and orthotics, activity-based rehabilitation, and health monitoring and maintenance. And doctors Charkar, Nat, Makowski, and Galanitis will all speak about different aspects of the APT Center program later on in the session. I'd like to say the APT Center focuses on what we call blue collar science. We're very applied and try to make a difference in people's lives, as you can see here. I have these are my disclosures, so let's move on. As Harry and Bob already spoke about, this is the technology we've been using. I'll talk about second generation systems, since the third generation is still in clinical trials for the upper extremity and will make its way into paraplegia soon, we hope. There are these implantable components, 16 stimulus channel implant or 12 stimulus and 2 bipolar recording channels. These nerve cuff electrodes that Bob introduced, these are the flat interface nerve electrodes that we developed and actually had their first in human application in individuals with paraplegia for standing, and intramuscular electrodes that are inserted in a cannula close to the nerve. This is an X-ray of the implanted system, an early system showing epimesial electrodes in the target muscle groups. And I want to call your attention, I don't think you can see it here, but one innovation of Byron's was the implantation of the electrode to excite the lumbar erector mass, to stiffen the lumbar spine and get the head, arms, and trunk over the pelvis, which is really the secret weapon that enables transfer, standing, and stepping. We've since focused exclusively on that and the hip extensors for seated posture and balance, which I'll have to talk to you about at another time. This system does not have batteries or any kind of internal logic. So it's controlled by an external transmitter that tells the stimulator which muscles to fire when and how hard, and the user interacts with that with a wireless finger switch or other wireless sensors like inertial measurement units. And I'll have something to say about that in a second. I want to summarize the history of this. We've had about 30 recipients of various incarnations of standing, transfer, and stepping systems, but this is a summary of the first 18 recipients who had systems implanted for at least 6 years follow-up. And the references for this are down below. We found that their functional abilities, that is the ability to exercise, stand, and transfer, reach overhead, or step, was maintained at 6 years post implant. We found that at follow-up, there is minimal body weight supported by the arms. Actually, better than 75% of the body weight was supported through the legs, which means that the upper extremities can be used for light touch, for balance, and not for support. The implanted components were reliable in that the stimulation thresholds which is the indicator of the proximity to the nerve and the efficacy of stimulation, neural stimulation, changed by less than 10% over that interval. So they're really stable. Stimulated strength also didn't change appreciably. And standing times remain consistent. I should say the average standing time was about 15 minutes, but the median was about 3 minutes, which means that the average was influenced by a couple of overachievers who could stand for 20 or 30 minutes at a time. So I think the outcome you can reasonably expect is about 3 minutes of standing, which is still plenty of time to perform functional tasks like reaching objects that are inaccessible from the wheelchair or transferring in and out of the wheelchair. I think it's important to note that usage time remained unchanged over follow-up too. People continue to use the system at home about an hour per day for about 40% of the days we surveyed, and that was distributed mostly to exercise and about 20% for standing for transfers, stepping, and other functional uses. So we are really encouraged by this long-term performance, and you can find the details in these papers. I'd like to speak about transfers for a second. People with paraplegia, I've indicated the injury level and Asia classifications here on each of these videos. Standing and reaching is fine, but most people's homes are adapted, and we really need to get this out into the community. What can we do to facilitate moving from, or facilitate really difficult transfers, that is from low surfaces to high surfaces, things that are impossible to do independently? So in this example, you can see a user getting ready, activating neural stimulation to her femoral nerves and gluteal nerves for knee and trunk extension to power her up and into her wheelchair from the floor. So as you know, a lot of your patients find themselves on the floor accidentally. And her response to this was, now I can get on the floor because I want to, and not because of a fall from my wheelchair, because she can get back into her wheelchair. This next gentleman has a bit lower level injury, and we tried to simulate a low sofa cushion, which, as you know, soft surfaces are difficult to transfer out of. And his response was, it's like butter. So in addition to those anecdotal demonstrations, we're trying to quantify the effects on transfers. And what you've seen here with and without stimulation is probably no appreciable difference, right? And that's the way we like it. In this case, the attendant is doing the complete transfer assistance. In this case, stimulation is on to the quads and the hip muscles to help, but they're being lifted at the same rate, performing maneuver, lifted to the same height, performing the maneuver at the same rate. But you see the assistant is standing on a set of force plates here. So what you see here is a measurement of, we simply subtract the body weight of the user from the assistant, and we get the percent body weight lifted by the caregiver. And what you can see is without stimulation, the body weight lifted by the caregiver is significantly higher than with stimulation. And if we look at the area under this curve, it actually represents the normalized work performed by the caregiver. So the caregiver is exerting, lifting less and for shorter periods of time, and the work they're performing decreases by about 16% just by having the patient do a little bit of lifting themselves by activating their paralyzed muscles. We're in the process of now quantifying what that means in terms of strain and stresses on the lumbar vertebral segments of the caregiver. And the initial, I don't have those results to show you, but the initial simulation results show that those stresses are also reduced significantly. So because most people with spinal cord injuries live at home with their spouses or their parents, and they're growing old together, we think this kind of assistance can help reduce the risk of back injuries to the attendant and potentially keep people out of long-term care facilities simply by making these transfers easier for the assistant. Other research regarding standing through the years going back to 2012, this is some modeling studies we did where you can see a biomechanical model that includes all the muscles that we can activate with stimulation. And when we push the model from behind, these are the reaction forces at the shoulder that have to be exerted to keep this model from falling over. And when we implement a closed loop controller that takes the acceleration of the center of mass of this model and uses it to modulate stimulation to the lower extremity limbs, these shoulder forces are significantly reduced. When we implement this in the laboratory, this is an individual with instrumented, her plantar flexors and her hip ab and adductors are innervated, and we're actually tugging on her with linear actuators in the orthogonal directions here, left, right, front, back. And similarly, we saw the handle forces, the exertion on the load cells here reduced by about 50% when those controllers are active. Now you can maintain your upright balance by changing your muscle reactions to externally applied perturbations. But once you get above about 30% body weight, once those perturbations are about 30% body weight, you have to change your base of support. It's just too much for your muscles to handle on their own. So we've actually implemented that strategy. You see here an individual, when we sense the jerk, that's the first derivative of acceleration of his center of mass. There are accelerometers on his chest. We can trigger a reactive step to change the base of support, the area base of support, and keep him upright and prevent a fall. So this illustrates some of the potential for closing the loop in these systems. Now, I'd like to pivot and talk about walking in incomplete injuries right now, incomplete spinal cord injuries, that I'll illustrate in two case studies. This individual has a C5 or T1 C5 level injury, T1 motor, C5 sensory. And our goals are to maximize his voluntary function. He presented similar to someone with hemiplegia. As you all know, incomplete injury, the manifestations are highly variable from person to person. His left side was more impaired than his right side, so we instrumented hip flexors and extensors, ankle dorsiflexors, knee extensors, and some muscles to stabilize his pelvis. On his left side, on his right side, we tried to help with at the hip. He still had almost grade 5 knee extension and plantar flexion on the right. So on the right, we inserted recording electrodes, as Harry alluded to, in his gastrocnemius and rectus femoris, which he still had near normal control over. What you'll see here is his baseline function about 2 years post-injury. He's braced on his more impaired side without stimulation. He's a physiologic ambulator, so he is able to walk after fashion, but he chooses not to because it's just too physiologically energy intensive. After implantation and rehabilitation with the system, well, this worked when I practiced, but not today. His walking is much more fluid. And so the question is that a therapeutic effect? is he just better voluntarily, or is it a prosthetic effect? Is it because of the interaction of the stimulation? And that's the answer, as you'll see in the next slide, is both. Okay. All right, so when we measured before application of stimulation, this is a 6-minute walk distance, you know, maybe about 30 meters. After 36 sessions of rehabilitation with the implanted stimulation system, gait training, he made a significant increase, you know, almost 4-fold in his ability to walk without stimulation, and a 20% increase in that 6-minute walk distance when a stimulation was applied. So there was a therapeutic effect and a neuroprosthetic effect. But when we asked him to walk as far as he could, he just kept on walking with the stimulation. So 3 times his maximal distance. His gait symmetry improved, double stance time reduced. His speed went up slightly. So this is where the neuroprosthetic effect really comes into play, far beyond, you know, walking distances are really increased far beyond what they are voluntarily as we use the system interactively. This is the EMG control that Harry alluded to. What we did was we triggered swing on his impaired side by detecting the EMG activity of his quadriceps when he was loading his less impaired side. And we triggered stance and swing to his stance to his impaired side and swing to his less impaired side when we detected him pushing off, plantar flexing on his good side. And here you can see, this video works, but here you can see, because this is tied to his voluntary motion, he can speed up and slow down, change his step length. He's not interacting with the system at all. He's not pressing any buttons. It's simply the EMG of his good leg controlling stimulation to both sides appropriately. And when we measure speed, you can see with the EMG control, he has the ability to vary his speed much more than when he's just fighting the stimulation with his arms to move faster. This also has the potential to reinforce desired muscle coordination patterns, so that there can be a real powerful rehabilitation tool here to train him to use his voluntary muscles more effectively. All right, in the second case study, I'll go through this quickly. This was someone with a low cervical level injury, 30 years post a diving injury, and she was ambulatory with crutches when she came to us. She did have some difficulty, mostly in swing phase, and her near normal knee extension, voluntary knee extension, led us to instrument her dorsiflexors and particularly her hip flexors entirely with these intramuscular electrodes. She had some hypersensitivity, so we tried to minimize the surgical incisions that we had to make, so we took an intramuscular approach. And we triggered stimulation by putting accelerometers in the baby shoes that she wore on her crutch tips. And so by detecting when she planted her crutch, we could trigger swing on the opposite side and vice versa. So here is her walking without stimulation. It's kind of gruesome. This back kneeing that you'll see caused her some pain. With stimulation, she was able to move much more fluidly. And as you can see here, her walking speed increased significantly with the neuroprosthesis. We were able to control that knee hyperextension modestly with stimulation. She walked for 6 years with this implanted, but that pain exacerbated and really limited her community walking. So she went from a household ambulator to a community ambulator with stimulation, but then that degraded over time because of the pain. So what she said was the stimulation was huge. Without the device, she'd be in a wheelchair. And when we did these tests, she said, if you think I'm walking 6 minutes without it, we did a 10-meter walk. She wouldn't do a 6-minute walk without the stimulation. She told us where we could put our science if we asked her to do that. 6 years after that, she received bilateral total knee arthrodeses, a hinged knee joint, and her, which relieved her pain. And as you can see here on the right, and in the video, her walking was much improved. The blue dots are without stimulation, and she was able to walk almost 200 meters and at a variable speed. But as with the first gentleman I showed you, with stimulation, even though the kinematics don't change appreciably, she was able to keep on walking after she had to stop voluntarily. And she was able to maintain that speed through the interaction of stimulation. So she said, with it, I can walk easier, farther, and with less pain. I don't need to worry about stopping to rest. And if you tried to take it away from me, I'd fight you. So with that, I'll bring things to a close and try to get us back on time. I hope I've been able to demonstrate that neural stimulation can provide clinically relevant and consistent standing, transfer, and stepping function in the long term. With good reliability, performance, and user acceptance years after implantation. Assisted transfers can facilitate daily function for the user and the caregiver alike. These stimulation systems are customizable for individual gait deficits that we see in incomplete spinal cord injuries. They can be integrated with intact volition, either through measuring the myoelectric activity of muscles still under voluntary control, or physical parameters like acceleration and jerk and snap of assisted devices or the center mass, and contraindications like that knee issues that the last subject presented can be addressed clinically. So contraindications are temporary, I think I would say, and there are ways that as clinicians we can modify their clinical presentation and make individuals appropriate for neural stimulation so they can take advantage of these technologies. And with that, I'd like to thank our funding agents, all our co-investigators, that team of thousands that make this possible, and particularly all participants and their families. And if you're interested in finding out more about this or referring patients, please contact our physical therapist at this phone number or this email address. Thanks. I'll take any
Question for
questions at your
Dr.
time.
Triolo.
If there are any questions, please feel free to email me, and I'm happy to chat offline.